that we all know who are participating. So this first speaker that we have today is Ashley Hume. She's the Chief Commercial Officer for Emerging Therapy Solutions. She's a 25-year veteran in healthcare and managed care industry, and she comes with extensive experience leading multidisciplinary teams, both in the provider and the payer spaces. So she's the Chief Commercial Officer, managing client-facing teams, as well as market strategy related to cost containment and risk protection for catastrophic claims. Ashley sits on multiple national committees focused on reimbursement policy and innovative payment strategies for cell and gene therapies. Prior to ETS, she held leadership positions at a health plan and health plan service company, and she has also held leadership positions over revenue cycle and contracting for large specialty groups and healthcare systems. So we're very fortunate to have Ashley here presenting some of the landscape around gene therapy. Next, we'll have Dr. Alex Boucher. He's an assistant professor in the Department of Pediatrics and Medicine at the University of Minnesota. He attended medical school at the University of Tennessee and completed his Med-Peds residency here at the University of Minnesota, followed by a pediatric hematology oncology fellowship at Cincinnati Children's. He's a classical hematologist who specializes in rare red blood cell disorders, including leading the pediatric and adult sickle cell program at the University of Minnesota. He also focuses on improving models of transition to adult care for complex pediatric diseases and mitigating healthcare inequities. Next, we have Ray Blaylark. She's president and founder of the Sickle Cell Foundation of Minnesota, and as well as the proud parent of a young adult son who lives with sickle cell disease. She founded Sickle Cell Foundation of Minnesota as a means to increase local and national awareness of sickle cell diseases, elevate the voices of the community, and improve health care outcomes for this underserved population. She's also a member of the Minnesota Rare Disease Advisory Council, so we're so lucky to have her. And last but not least, we have Scott McGowan, and he is a dad, a nerd, and an executive director for policy and alliance development at Vertex Pharmaceuticals. He leads policy and advocacy for genetic therapies, and over the last 20 years, he's had numerous roles in the biotech and medical product field as a researcher, policy expert, and fierce advocate for patient communities and access for gene therapies. So with those introductions, I'm going to go ahead and ask Ashley if you will lead it off with your presentation. Take it away, Ashley.
You bet. Thank you, Erica, and thank you all for taking time to learn more about this incredible time that we are experiencing with all this innovation as it relates to potentially curing rare diseases. So I think the slide, I can't see the slides. Are they, can everyone see the slides? Oh.
1 second, I don't think we have them pulled up yet.
Okay, perfect. Well, I hope everyone is enjoying this beautiful weather. I think the majority of us are in Minnesota, and I just had a minute to grab a package off the front steps, and I'm sad that we're not outside. So I hope everybody's enjoying their day. All right, well, we can get started with the next slide. So just briefly, ETS, so our organization, we are located here in the Twin Cities. We're officed right by the airport in the Mall of America. Our company came to market in 2019, and our founder and co-founder really spent the majority of their careers in the managed care industry. And our founder specifically started URN back in the late 80s or the early 90s, and that became United Healthcare's transplant network. And really, they looked at this space with cell and gene therapy and said, this looks just like transplant did back in late 80s, early 90s, and we need to put services like it around cell and gene therapy. So our organization really works with a variety of different risk-bearing entities to help prepare for and ultimately pay for these therapies, really with the end goal of supporting patient access. Next slide. And next slide. So just to level set, when we talk about cell and gene therapies, there's a lot of words, and I will let Dr. Boucher focus on some of the clinical aspects. But just to level set a little bit, when we talk about cell therapies, we're talking about high cost cell therapies. So right now that's CAR T therapies. There's a lot of additional types of cell therapies coming to market, but this doesn't include, you might hear of someone having a cell therapy for their joints or having sort of osteoarthritis type of cell therapies. Those aren't really the focus of the conversation today. Same concept with gene therapy. We're talking about therapies that replace or remove or edit or in some way correct a missing or malfunctioning gene. And that's sometimes confused with genetic testing or other kinds of precision medicine, but really we're talking about those incredibly high cost therapies that are coming to market with potential incredible benefits to patients. Next slide. So this is, albeit overwhelming, but this is a listing of the current approved therapies that are on the market as of today. And I obviously don't have time to go through all of these, but I will just touch a little bit on what you're looking at on the slide. So you're looking at the listing of therapies and where you see the therapy list cost. That's really important. That's actually the wholesale acquisition cost for the therapy. But in many instances, specifically with the cell therapies and with the ex vivo gene therapies, we're looking at an additional $300,000 to $800,000 in administrative costs. So that's the physician charges and the facility, the hospital charges to actually deliver the therapy when you look at that sort of total episode of care. So these are incredibly expensive therapies that have, in most cases, incredible results and benefits to the patient. I'll just touch briefly on each of the categories, but before I do that, I want to just call out, if you look at the approval dates for these therapies, you're going to see that there were 6 therapies that were approved in 2023. And prior to that, it took, 4 years to get 6 therapies approved. So there's really a significant increase in focus right now on getting these therapies to market and through the approval process with the FDA. There's also a huge commitment from the FDA to put a lot of energy and focus and staffing around, helping these therapies through the approval process. So when you look at just back for 1 second, sorry. I just want to point out one more thing on this slide. So in the cell therapy space, those are mostly for right now, they're all for cancers. And those are kind of at this point, working really well within the industry. And folks at this point, there's some billing methodologies and that sort of thing to manage CAR T therapies. That said, I will say that if you were to ask the facilities, I think they would tell you that, especially from a government payer perspective, they are not valued appropriately. So they're not necessarily, if you look at the payment methodology, set up to cover cost. So that is a consideration when we think about patient access and those facilities making decisions about whether or not they can provide this kind of care. In the gene therapy side of the slide, so the in vivo gene therapies, that means that the member's having an infusion and the work is happening inside that patient's body. So there's not necessarily a huge administrative cost, but they're very expensive therapies. The ex vivo gene therapies underneath it, those are more like a bone marrow transplant that have a gene therapy included. And so those are very lengthy and resource-intensive procedures to provide the therapy to the patient. And the last thing I want to point out on this slide, we're here today to talk about sickle cell, and sickle cell is just an incredibly challenging disease for a myriad of reasons that I think probably Ray will touch on more, but it's an incredibly challenging population to address. But there are other gene therapies. For instance, there's a gene therapy for Duchenne muscular dystrophy that recently came to market. That's a therapy where prior to and currently, there really isn't other treatments available for those patient populations. And so, very similar to sickle cell, where there's very limited opportunity for those patients. And I just want to contrast that with some of the other therapies, for instance, hemophilia, where there are therapies on the market, that are an option for patients. So this is really confusing for the payer industry, just because when they're looking at coverage considerations and whether or not they want to sort of expedite getting these therapies through their processes, it's something we spend a lot of time helping them understand the urgency with a lot of these therapies. Next slide. So this slide is a listing of the therapies, the conditions that we believe will have a therapy work its way through the FDA approval process in the next 12 to 24 months. And so this is really where we're spending a lot of energy preparing for these additional therapies that will be coming to market. Where you see the word PDUFA, which is a funny word, but that means that the FDA has already set a date that they have to make a decision by. So the therapy has already gone through its filing process and it's in its evaluation with the FDA. So there's going to be a significant number of additional therapies approved yet this year. And lots of activity in the oncology space. But again, just so many orphan diseases are on this list. And again, really bringing a lot of focus and attention to getting processes in place to manage these populations. Next slide. So this is, there's a lot on this slide, so I'm just going to orient you briefly. We have a data partnership with an organization called Clarify. So we have data on about 200 million lives in the US, and our organization does a lot of analytics for our client base. If this is a simulation of a commercial population in the United States, a 1 million member health plan. So in 2020, when there were 5 available indications on the market, you would have expected maybe 7 patients to work through this process. And the total cost of care to deliver care to that patient population is that bottom line. And PMPM is per member per month. That's how the health insurance industry measures cost. So it would have been about $1 PMPM to manage this patient population in 2020. In 2023, there's now about 31 indications on the market. And so now that 1 million member population has about 40 people going through the process. And so now we're looking at over $5 PMPM. But looking forward to 2026, we anticipate up to 50 available indications with now 120 patients that might have access to these therapies. So we're at about $16 PMPM. So as you can see, it's just a significant, almost hockey stick effect that we're expecting over the course of the next few years. Next slide. So that's just a little bit of landscape about what's happening right now. But I want to briefly talk about really who's impacted by this. Next slide. So, really at the core is the patient, and that is why we're all here. And that is what's just incredibly important for us to all kind of keep as our North Star in this conversation. But there's a lot of other stakeholders, as you can see, and this is a really high level explanation of who the stakeholders are. But what I want to point out as the sort of representative of the payer community here is that payers mean a lot of things. And what's super unique about this space, we have our government payers, which is our Medicare and our Medicaid. We have employers who, 65–70% of the employer market is self-insured, which means that they're covering the cost of these therapies. And it's a significant portion of our client base is helping to support those employers. We have the health plans and all the different types of health plans that all have their own levels of sort of owning the risk as it relates to the cost of these therapies. And then we have the secondary payer market. And I think that's a new concept for a lot of people. So I am going to talk about that briefly on the next slide. But what I want to talk about is that historically speaking, when there's a new biologic that comes to market or a new drug, people are in most people's understanding is that you're working with health partners or Blue Cross or maybe the PBM. Lots of people are familiar with the concept of a pharmacy benefit manager. With cell and gene therapy, there's a new stakeholder, and it's almost the primary stakeholder, and that is the secondary payer market. So that's your stop loss and your reinsurance. Next slide. So this is just a brief illustration of what that means. But if you look on the left at that little graph, so let's say that we have a claim that's about 3.8 million, which is what you might expect for a sickle cell patient, depending on which therapy they were to receive. So at the very bottom in tiny print, you'll see the patient. So if the total claim cost was $3.8 million, the patient's going to have maybe their $7,000 out-of-pocket cost. then their self-insured employer is going to pay maybe $250,000 of that exposure. From there, it's going to go to employer stop loss, which is the type of insurance that employers buy so that they're not on the hook for the whole 3.8 million. And stop loss is going to pay maybe about $1 million of that total cost. And from there, it's going to go to reinsurance, which is essentially insurance for insurance companies. And reinsurance is going to bear the majority of the cost of this claim. And that's going to be true both for commercial populations as well in a lot of states, Medicaid populations. And so that's just something I wanted to kind of call out, that the stakeholder from a payer perspective is really shifting in the cell and gene therapy space, because even though we have to count on, the benefit administrators or the TPAs, the third-party administrators, to really manage the patient as they work through the process and their medical policy and their prior authorizations and all of those sorts of things, ultimately who's going to pay the bill is shifting. Next slide. So just briefly to touch on a lot of the challenges that the payer market is facing right now. I already briefly touched on this, but with the government payers and in the sort of Medicare and Medicaid space, the rate structures that are in place right now are somewhat inadequate as far as the actual dollar amount, and it's complex. So when a new therapy comes to market, it takes a long time for the industry to kind of catch up and come up with a way to pay for that service. So it does become really complex for the folks that are trying to make sure the provider is being paid fairly and that there's money that has been reserved to pay for these therapies when there isn't necessarily a great structure in place to actually bill for the services. There's a huge challenge, especially at the national level, because of state-specific coverage guidelines and prior authorization criteria. As a therapy is approved by the FDA, it has to be covered by Medicaid, but how it's covered varies significantly state to state. In addition to that, can you hear me? I'm sorry, I got kicked out there briefly. So there's state-to-state access issues that cause significant delays in patient care, and it is something that really needs to be addressed. So that a lot of times, as I referenced earlier, these are time-sensitive patients that need to receive the care as quickly as possible. In the commercial payer space, really there's a big push right now to move towards value-based payments, and that is a challenge both for the manufacturer to be able to agree to kind of the guidelines for those value-based payments and then work around some of the regulatory structures that are in place for that. And then you have to monitor that patient. In some cases, the expectation is for 15 years. So keeping that patient as they move from payer to payer, provider to provider, employer to employer, that's incredibly challenging. In addition to that, we're seeing what are called lasers from stop loss and reinsurance. So if there's a known exposure, if they have a patient in a patient population that they know has a condition, so they see the patient has had factor for their hemophilia in the past, that stop loss carrier can just unilaterally exclude that patient from coverage, putting that onus back on the employer or ultimately the member, or having them drop to Medicaid. And so those are some significant challenges. And then for the secondary payer market, this is new to them. They use actuarial processes that have been around for a century to decide what their risk looks like going forward. But that's based on trend. And these are brand new therapies, so there really isn't any trend for them to rely on. Next slide. Next slide. So, really kind of what's happening right now, what we're seeing in the market, we are seeing coverage. For a period of time when things first came to market, there was exclusions when a new therapy was approved, but the payer industry, for the most part, has now determined that they need to actually cover the therapies. However, they are, in some instances, not covering them as investigational if they're working their way through an accelerated approval pathway or things of that nature. They're putting a lot of prior authorization requirements in place, which is complex and makes it difficult for members to be able to access the care. And there's some step therapy requirements that have been put in place. We are seeing a movement towards value-based payments. There is actually a new infrastructure that CMMI released yesterday that they're working towards putting a sort of national option out there for value-based payment administration. So that we'll see what kind of comes of that over the next year. And then requiring the use of centers of excellence is certainly on the docket as well. Next slide. And as far as kind of what's next, we are seeing a lot of syndication and risk pooling, a lot of movement towards value-based contracting. There is a lot of discussion around, is there an option for state or federal pooling or program management? Again, centers of excellence, and then alternative funding. There's a lot of new models coming forward that kind of look like putting a mortgage on a cell or gene therapy. Next slide. So what can we do now? And I know I'm just racing through this, but I think I'm already over my time, so I apologize. But really how we work with our client base is helping them to understand their risk. So really not just from a cost perspective, but also how many patients might you expect to see. That's a really important process and program for kind of getting ahead of this, and would be incredibly critical for the state, both from a Medicaid perspective as well as even the state employee perspective. So really getting ahead of that with analytics, determining who and what to cover, being really thoughtful about your coverage criteria and making sure that you have your ducks in a row so that you aren't delaying care and that the right patients are receiving the right therapy at the right time. And then really end-to-end risk management with centers of excellence. It's sort of how it all comes together. Next slide. And at ETS, that's really been what our focus is. We have put together a national program. I think everybody's familiar with centers of excellence. They've been around for decades. We've put together what we're calling programs of experience for cell and gene therapy. And so we're working with the national experts, physician experts from all over the country in these different conditions and therapeutic areas to really understand, with these brand new high cost, high value therapies, what criteria should a facility have in place to be able to deliver these services in an incredibly high quality environment, and also ensuring that the members have the aftercare that they need to be successful. And with that also, there is a cost component. So really ensuring that markup is addressed, because that is a significant consideration, especially on a national level. The cost of providing these services varies significantly from facility to facility. So that's really the goal, is to identify the patients early, get them to a center of excellence, ensure they're thoroughly evaluated to ensure they're the right candidate for the therapy, and then have contracts in place to ensure that whoever the risk taker is, that they know what to expect as far as how much it's going to cost. And I think that's the end of my presentation. So thank you all, and sorry I was racing, but appreciate it.
Thank you, Ashley. Thank you for giving us that kind of overview of the landscape. And Alex, if you would like to come on, and we want to kind of bring it at the end of the day, we want to talk about patients and how these innovative products are being viewed by the clinical the clinical field and by the patients themselves. So Julie, if you could pull up Dr. Boucher's slides, and then
thank you.
I'm giving you the floor. Thank you so much.
While we're waiting, thanks for the opportunity to share this. See some familiar names and faces from the RDAC Council. There we go. Perfect. So I want to share my perspective from the clinician standpoint. So as it says here, I direct our sickle cell disease program. I have the unique opportunity that I'd say there are very few people around the country, and certainly I think I'm the only one in the upper Midwest, who does lifespan hematology care, which gives me the opportunity to meet with families after their newborn screening shows it. So yesterday I met with a 4-month-old, a family of a 4-month-old with a recent diagnosis, all the way up through towards the end of life, which unfortunately in our patients' cases often sits in the 50s, in their 50s, maybe their 60s at best. Next. So, I wanted to kind of talk about what could be different. What does this look like? I have my disclosure as a well-behaving academic. We talk about our disclosures. I will say the CSL Behring is a sickle cell phase 1 drug study. And I do help with the MDH and their CDC grant to work on epidemiology. What you don't see here, importantly, is I have no link research-wise or other with any of the gene therapy companies. I am a step or two removed from that. I consult with my colleagues who are in the bone marrow transplant cellular therapy space, but that's not my job. So I am giving you the perspective of what does it look like as the natural history, and then what do I have to tell my patients or discuss with my patients, and how do I think about this in the larger context of sickle cell care, when it comes down to that referral process. What does it look like? What does it look like potentially afterwards as well? Because as Ashley pointed out, there's a 15-year follow-up, which in many ways they come back to me because I still have that knowledge base of following side effects, but it's it's sort of in our survivorship oncology model that we're thinking about it. Next slide. So I want to talk about these inequities. I know that Ray will talk about it from the patient and family perspective. I want to really set the stage from the medical historical perspective. Why are we at this point where we still feel like, even at a point that has a potentially major trajectory change for our care, still feeling like we're clawing, just trying to get a foothold, really with a chip on our shoulder, and then again recognize those potential effects that they can have. Next. I'm going to start with a case here. I will say that the patient here that I'm presenting, I've changed a little bit of her demographics, but she has given me the approval to kind of share her perspective, so to speak, or at least her medical history to help paint the story. So she's 28 years old, lives in northern St. Paul. And she had started out as an undergrad at a major state school, but that and has still started kind of intermittently through college. A lot of the stops and starts in the intermittent educational pathway she's taken has really been based around her medical care. And so in many ways, she's not matched with her peers, because many of her peers, if they went to school, are done by now, have been done and out in the community working or doing whatever they want, but she's still trying to kind of make that happen. That vision is still there, but she hasn't been able to, because as you can see, her medical history is long, but unfortunately it's pretty typical. So not only are there the surgeries that were mentioned at the top, but joint replacement. So I don't think most people know, including some orthopedic doctors that I was talking to recently, that the average age for any of our patients to have their joints replaced is really in the late 20s to early 30s. And so the fact that she's already had her shoulder replaced and due to have her hip, that's actually pretty typical. And so, that's just one example of why this is a different disease. This has to be thought of differently, because the perspectives of what we're used to seeing just don't fit. I've been here 4.5 years at this point, in my current faculty role. She was one of my first few patients, and she was in the hospital a lot. You can see here, we've really dialed that down. It's not down to 0, but she's able to, again, maintain her academic pathway a little bit better, have a quality of life and relationships that aren't circling around hospital stays. Even her pain medicine, we've been able to get down there. But this is a typical story. Next slide. So let's talk about the history here of how we got here. Next. I want to kind of paint the picture for epidemiology. I recognize that most of the folks here are not clinicians, and I'm not going to try to teach you everything about the biology of sickle cell disease. But what I can tell you is that there is one single spot. It's always the same one that turns the hemoglobin A, which is normal or adult, into hemoglobin S. That one little change, which is consistent throughout everybody with sickle cell disease, is responsible for basically this multitude of complications. It changes the protein in a way that basically doesn't hold on to oxygen very well, and has all these downstream effects. And because blood goes everywhere, truly every organ system can be affected, all the way out to the skin. And these are things that may have the ups and downs of intermittent pain crises, or they have, and more often have, a progressive indolent sometimes silent early. So, for example, patients who aren't on hydroxyurea, which is our standard of care oral medicine, have about a 11% chance of having a silent stroke before they're 10. And that's separate from having overt strokes, but those silent strokes often show up as educational difficulties. These build up over time. And so that's why I have this picture of the sort of Damocles here, that there's this idea that somebody's trying to go through life, thrive despite this disease that, of course, they didn't ask for, but were born with. Yet there's always that danger lurking around that corner. There's always that risk that whatever plans you put in place for your life, your career, your family, et cetera, could get derailed by something that even if you've been doing the best care you can, you just can't expect. So if we think about it from a prevalence standpoint, and these are really raw numbers because historically no one's actually thought to look. This is one more example of the inequities. The 100,000 people in the US, which for perspective, as Ashley pointed out, thinking about, say, hemophilia, 33,000 people in the US, in that case, generally boys, have hemophilia. Cystic fibrosis, which is usually our comparison, to be honest, because of the race differences, 33,000. So we're talking about a disease that, even at our rawest estimate, is 3 times that much. And if you look at it globally, it's not a rare disease. It is a very common disease. And it's also not just in somebody affecting people who are from sub-Saharan Africa. There are millions of people born in India. It's the second highest birth rate in the world. But those patients have the same socioeconomic barriers that our patients in the US have. So just to put that in perspective, it's called a rare disease because we estimate that there's fewer than 200,000 people, but it's only just now that the CDC has come around to trying to find that out. And even in that best case scenario, we have 12 states out of 50 trying to find that out. So we're far behind the curve. Next. There we go. So these are numbers from my colleagues at MDH, just to kind of look at what does it look like here. So the curve they have, these are from the all-payer claims database. For perspective and why the numbers don't match, these are at least 3 diagnoses codes of sickle cell disease in a 5-year span. And so you can see that it's 800 to 1,000. But if they run the numbers and say that there's patients, if we include those who are 1 or 2 in the system, we're talking about a much higher number. And even in that case, it's probably an underestimate because these are patients these are using Medicare and Minnesota Health Program enrollees and then commercial enrollees. Now, most of ours fit in that larger category, so the numbers aren't probably drastically different. But just to say that this is a disease that is out there, it's, it is not some sort of shrinking violet. And as we compare it to other diseases who have had other opportunities for these gene therapies, it's actually higher. It's a higher prevalence than those. Next slide. This is what it looks like on a time scale. And I have in there the medications that are in bold, just to put in perspective. So we've known about this disease for 24 years. Next, you can see that it took 62 years to get any kind of federal funding, right? So we were in this wasteland for generations of not knowing, of really nobody being interested in sickle cell disease. 1972 rolls around. This is a political statement more than anything else from Nixon. There was they actually, if you read the law, it says they think 2 million people in the US have it. They were grasping at straws, but it at least opened the door. But then next slide, you can see it still took 26 years to get one medication. Next. And it took 108 years until we actually got to this cluster of more than one medication. So Andari was the second one, and then, but it even, you can see it took 20 years almost for it to get approved in peds. We're talking, if we talk about this cluster in blue at the end, we're talking about a very small window of time where there's actually been any kind of emphasis on sickle cell disease. It even took 30 years for all states to do newborn screening. I think New Hampshire was the last one, and it was like there are still theoretically patients in the pediatric population who wouldn't have been screened. So that's what we're dealing with. That's the chip on our shoulder. These are the inequities we've been dealing with. Next. And this is part of it why. This is not just a community issue. This is a medical issue. So this is the editor of JAMA, one of the foremost voices, even now, but certainly back in 1947, saying that, it's pretty cool that under the microscope, these red cells sickle, but what I find the most fascinating is that this is a racial disease, basically doubling down saying, if you don't think they're Black or from Africa at some point in their 23andMe history, you just haven't looked deep enough. That's a problem. That's why it took at this point, 25 years, they were actually just case reports of non-Negro patients with sickle cell disease a few years prior. So these are things that aren't just a community issue, these are a medical issue. And I think I still fight those things, but this is pervasive. This is the community we live in. We cannot separate those two. That racism, that structural inequity happens in the hospital, happens outside the hospital as well. Next. And so this is, this is the curve from 1970. This is one of these classic curves in my world that we see. If you look at that, the 50% survival essentially is at 18 or 19. So half of the people with sickle cell disease before that were dying before they hit adult care. There probably wasn't much need for an adult sickle cell provider at that point. You see, and on the right side, for perspective, the x-axis is median lifespan, and the y-axis is these different events. You can see that once you start to put some money towards it, once you start to put some research into it, you get a generational change. I mean, you get essentially a 2 to 3 times expansion in your lifespan in a generation. That's significant. That's what this new push has really meant, is that this potentially changes people and families' lives in a way that is more than just adding another pharmaceutical agent. Next. But what you do see is, in reality, we've lost that trajectory. Until maybe now, until these opportunities, we've kind of plateaued, and that's why our median lifespan is still in the low 50s. Next. And as you see here, this is just one more perspective. This is when, you say, oh, this is a long time ago, 1979 and 88. I have colleagues who were practicing back then, so it's not that long. But that crude death rate per 100,000, these were kids dying. And next, you can see a little shift. This shift that we see is not because of new pharmaceuticals. It's actually because we started giving kids penicillin to prevent new invasive pneumonia before age 5, and we started doing newborn screening. So nothing that was sickle cell specific, but that changed it. But now we're talking about, okay, you're still likely to survive 20 or more years less than your age-matched peer if you don't have if you didn't have sickle cell disease. Next. And the numbers are still there just to sort of hammer it down there. And there's one more next. These are recent data that the young adults, this is why I focus on this, that going from adolescence to adult care in a large inpatient sample of lots of diseases, there was already an increase in going to the hospital, but sickle cell is the only one that patients are actually dying at a higher rate. Right? That's a problem. That's a problem in our system, but in reality, that's a mirror of the larger community. Next. And then it's also just coming to the hospital more. So this is a different study, different group, but looking at it, sickle cell disease versus these other diseases which affect young adults in transition. Sickle cell is on its own curve. And these data about public insurance and unplanned readmissions, those are the real life experience. Patients are not going to different hospitals because they're drug seeking or something else. They're going because they want respect. They want somebody to just trust them. And they're just trying to be heard and respect and treated in the same way as they've seen other people sitting in the same ED be treated. So that's why people are bouncing around. Once they find a home, and I can attest to that in the Twin Cities, once they find a home, they stay because they finally find a system that actually pays attention to them. Next. So then it comes down to in the next couple of questions, why should we care? Next. Here's why I think you should care as the government, because you pay for most of this care, right? So when the AHRQ data, there was a study that looked at the database. This did not include Minnesota, but include most of the South and in the Northeast. Basically, those patients who had acute healthcare encounters, it was twice as likely if they had public insurance. Next. And there's a high rate of rehospitalization, right? And so we know CMS doesn't pay for those, and hospitals get penalized. That's a big deal. Next, this is what it looks like in our system. That's most of our patients, right? Just for perspective, like I said, I've been here 4.5 years. When I started, we had 77 adults in our care. We have 180 now, over 180. These are not patients who suddenly developed sickle cell disease in the last 4 years. These are patients who are coming to our system because we have put out our shingle and said, we want to do this well. We want to keep optimizing it. We've made ourselves as a center of excellence statewide, well, really nationally, and have that recognition. But also we know that my colleagues like Paul and others have the opportunity to do curative therapy in a place that actually set, historical standards for that. So we have everything from the bench work with the mice all the way to curative therapy. Yet we recognize that this is the payer mix that we have. And that growth, these are a couple of years ago, hasn't much changed and may even be higher. Next. So that's why I think you should care. This is why I care, because I go back to my patient and I think about what would it have been like if 10 years ago we had this opportunity. She probably wouldn't have needed her joint replaced, and maybe not the next one. She may have been able to have a different academic pathway. This ripple effect, right? It's not just what is the cost of the therapy, it's what is the value lost to the community. What is that value lost when she didn't get her academics, which means that she didn't join the workforce, which may have meant that she could have gotten commercial insurance, but now she's not, right? These are the things that aren't seen on an Excel spreadsheet, but are the real life manifestations that we see. We have patients who have had strokes. I have a patient, one who's working downtown Minneapolis in the business sector, but he had a stroke just within the last couple of years. Not only does that affect him just physiologically, but it means he has to come in now every month for transfusions for the rest of his life. We've had, and that's not including patients who had strokes in kids, which we also have. 3 have died before age 30 of sickle cell complications. So and then what about those babies? Like I said, that 4-month-old I saw yesterday. Their experience will be very different, hopefully, than the life experience of my 29-year-old in this case. But I need to be able to offer that to them. So the next slide. What we are sitting in is I'm sitting in the University of Minnesota, who has led the world in bone marrow transplant and cellular therapy, and we're recognized as a center of excellence. And I truly have had these discussions. I had them before the approval because I knew it was coming, and I've had them after. That I have to sit in rooms with patients and their families and say, look, I'm really hoping that we can get you into a trial, because we have a queue for that, by the way. We have a lot of patients who come from a 5-state area to our institution for that. Because right now, as it stands, nobody wants to pay for this. I have nothing to do with the price. I think it's very high, and it's only a bit part of the cost. But the reality is I have to sit there and say, look, the FDA thinks this is safe, but the only way that we can pay for it right now is to do something that's not FDA approved, being a new gene therapy trial, for example, because nobody wants to pay for it. That's a moral hazard that I have to deal with. That's a situation that's real. That is a situation that I've had to have that discussion on multiple occasions, and it's not comfortable. Because I have to say, look, I really want you to be able to get this, but I'm not sure you can get it because your insurance is such. So with that, I think the last slide is just a thank you. It's a challenging topic. This is the reality of the care that we provide. And I recognize that my job as a non-curative clinician, so to speak, is not going anywhere soon. But man, I really wish I could be able to offer opportunities to more patients. Thanks.
Thank you so much, Alex, and thank you for helping us sort of juxtaposition the clinical dilemmas that you have and the challenges to the payer system. Thank you so much. And with being able to hear it from a clinical side, I'm sure there's going to be questions for you. We'll hold those till after we hear from the next 2 presenters. So next I want to ask Ray Blaylark if she would unmute herself and talk to us a little bit. We've heard sort of the general landscape, we've heard from the clinician, and now let's hear from some of the effects on the patient community. Take it away, Ray.
Okay, thank you very much. I have too many windows open. What an honor that it is to be here amongst you all. We really appreciate this opportunity. It's important. Each person has presented very, very important aspects to caring for sickle cell disease. What we want to make sure of is that the patient stays at the center. And my dog knows whenever I'm on camera. And so it's important that we really kind of break down an understanding of the community, who they are, how they live with this disease, the impact that just living day by day with a body that encompasses a disease of this severity has on them, and what the potential benefits could be to others who are able to access this care. So much like Dr. Boucher, I have some disclosures to make. As a community-based organization, we are involved in a number of things, as you can see on the screen. That includes in Minnesota, the Newborn Screening Advisory Committee, the Minnesota Rare Disease Advisory Council. We do work on a HRSA project within our region with the sickle cell treatments and outcomes research in the Midwest. And then we work with local clinics right here in the Twin Cities as well. We're going to just simply walk through just the anatomy of a warrior, that sickle cell biopsychosocial superhighway that everyone has really talked about. And then what is that potential impact that gene therapy can have upon the sickle cell community? I always like to start with the anatomy of a warrior. What is a warrior? How do you define a warrior? Why do we call them warriors? So when we think about being a warrior, and this is, I don't want it to fast forward. We think about generally a warrior as a person who's engaged in or experienced in warfare, or more importantly, a person engaged in some struggle or conflict. When we say sickle cell warrior, what we're talking about is a person who lives with the physical, the mental, the emotional, and the social complications and implications of sickle cell disease, yet they face that journey ahead in spite of unimaginable pain, what they feel to be medical abandonment, stigma, negative messaging, very few treatment options, a non-empathetic workforce, repeated death of friends and loved ones, and an uncertain financial future. Now, it's important when we talk about a sickle cell warrior that we also talk about the warrior caregivers. Those are the parents, those are the aunties, uncles, grandparents, the family members, the friends, those who are charged with providing that quality of life or supporting quality of life. If you're a parent, you are looking at those concrete needs. If you're anyone else who's supporting or caring for someone, even a spouse, those concrete needs, the emotional needs, the physical needs, all those things that we talked about a person living with sickle cell disease. But it's notwithstanding that caregiver's own physical, mental, emotional, and financial needs alongside that journey. Now, I would never do justice if I did not introduce my own warrior. That is my son, Trayvon. He's now 27 years old. His journey is very interesting and full of lots of fun twists and turns and details that have impacted his quality of life greatly. This is also my warrior, very same person, but a different day. This happens to be, he ended up getting COVID very, very early on, and he works in a group home. And as we know, it was spreading. It was very new. They did not yet have a vaccine. One of the things that they had to do is give him an exchange transfusion. That took 8 units of blood, 8 individual donors who had to donate their blood, and they had to match it to him in order to replace his full body of blood in order to keep him alive. That lands differently when you're a parent. That lands differently when you're a provider. That lands differently when you have a stake in the outcomes of an individual and a community. Just very quickly, I'm hoping that this will show. I think this is important to see. Oops. Let's see if we can get it to play.
Price, place, and anyone?
Living with sickle cell disease is torture.
John, let's have you share with the class.
Everyday tasks can be filled with pain. I am one out of every 365 African Americans who have sickle cell disease. You can't see our pain, but please believe it.
One of the greatest challenges of living with sickle cell disease is simply being believed. And that's what creates even more of a biopsychosocial burden on this disorder. And so it's important that we address all of these issues if we're really going to change the trajectory of these individuals' lives. The first thing, and it was pointed out earlier, and I'm so grateful that it was, sickle cell disease is not a Black disease. It is a blood disease. And in fact, it's the most common genetic blood disorder in the entire world. From a global prevalence standpoint, there's over 7 million people living with sickle cell disease, with over 400,000 who are born every year. You can see from the map that it is not, just in Africa, but it is all across the world. On every single continent, you will definitely find sickle cell trait that is prevalent, with over 300 million people who carry it and can pass it along to their children. But the prevalence of it is sometimes mind-bending to me that we've gotten this far along without doing more. And here we are at the crossroads of doing more. It's important to also know between 20 and 2021, the birth of babies with sickle cell disease increased globally by over 13%. That means that also increases the number of people living with the disease. We're living longer, of course, because of penicillin and some options for treatments, certainly not enough, but the number of people living with sickle cell disease increased by over 41% between 2000 and 2021. That's significant, and we really have to take that into consideration when we think about where are we going with treating sickle cell disease. I did hear it mentioned that the prevalence of sickle cell disease in the US, you see that they believe there's about 100,000 individuals living with sickle cell disease. When you compare that to other conditions, it's not because one is worse or better in their importance. However, we see that there's a significant difference in prevalence and those who are affected. Oftentimes, as comparing the amount of the distribution of funding and other things that would actually assist in improving quality of life for these individuals. Not going to do the medical overview, but as Dr. Boucher talked about, the complications of sickle cell disease are far and wide. Blood travels everywhere. That means that complications of sickle cell disease occur everywhere in the body system, everywhere. So everywhere blood flows, there can be complications, and there are complications that are devastating that are associated with each of those body systems as well. Now, the sociological impact of sickle cell disease is where the barriers really come in, because you're talking about a chronic condition, not only chronic, but also acute, which means it shows up at any given time and in any situation. I can attest to that as the mother of a young adult for 27 years, whose life has in fact been disrupted, whose quality of life has changed as a result of sickle cell disease affecting our families. But it affects everything that you can imagine, from the housing, education, employment, even food security, transportation, particularly if you're a family who either doesn't have a vehicle or only has one vehicle and multiple children, from single family households to even two-parent households. But that individual and family income is changed tremendously. Those inabilities to prioritize your health is what impacts your medical and your social burden. Now, this is a busy slide, but what I really want you to get out of this is that the psychological impact of sickle cell disease really revolves around that frequent pain, hospitalization, that loss of schooling and employment, but it is the emotional burdens of living with this condition. And ultimately, the ability, as you'll see in the last two bullet points, to finding a provider who cares, finding a provider who has some expertise, and finding a provider who will offer you and can help to get covered the treatments that are right for you. And because of that challenge, there is an enormous emotional burden around premature mortality, death. When you see death all around you, you oftentimes wake up wondering, when will it be my turn? We don't want people to live with that on their shoulders. Now, when we think about mortality in children younger than 5, the total mortality is about 12th on the list as compared to other more specific causes of sickle cell disease mortality. But when you combine them all, sickle cell disease mortality is 12th. That's devastating. So as we wrap up, the potential community implications and benefits of gene therapy in sickle cell disease, because access really does matter. So we have to address that. But we also have to address how the community feels about the lack of access and about the lack of treatment. And I use this slide quite often because from the community's perspective, whether you're a patient, a family, a provider, a patient advocacy group like us, it feels like you are the only firefighter trying to fight this humongous house fire, and in fact, community fire, right? And what they feel like is happening is that the systems who can impact this are standing on the outside of the house. Some standing around helping, some, with a small stream of water. But the fact that it feels like there's not enough people who are contributing to helping the situation when compared to the enormity of the problem and the challenges that we face. What we currently see in our approaches is often that one, that one fireman that approaches the house. What we really need to have is an approach that involves all of us. That's the individuals, communities, the institutions, the systems, and the policies that are all working together to make a change in this community. And gene therapy is a perfect opportunity. The access to gene therapy, the coverage of gene therapy treatments is a perfect opportunity for us all to work together to make that happen. So we don't want the current approach. What we want is the potential for this new approach that involves all of us working together. Now, the potential community impact of gene therapy and sickle cell disease. These are some of the potential benefits, but that community health, overall community health, we know that there are disparities in healthcare outcomes within the Black community. They're even deeper when you narrow it down to certain conditions, sickle cell disease being one of them. But what about workforce contribution and engagement? We know that there's lacks in the workforce right now. There are people, I work with people and talk with families and clients every day who want to go to work, who are unable to go to work, who are unable to keep a job, who are unable to get the benefits that would ease the burden, even socially, but even in their own family setting. Family planning and relationships, when we look at how many people are living with sickle cell trait and the potential for those individuals to have a child with sickle cell disease. Imagine, trying to date. Imagine trying to decide, do we proceed with having a family and having our own children, and some not knowing their genetic makeup, others knowing, and the risk factors that come with that. Financial growth, of course, when you're able to work, you are able to afford your own care. You are able to afford life differently, and quality of life looks different. Decreased healthcare needs. I heard it kind of touched upon, but less interactions with the healthcare system. The healthcare system we know is overburdened, and because the needs of people are very real. To be able to interact less with the healthcare system is a benefit to both the healthcare system as well as the community. And then we can focus on what are the primary needs of primary care for an individual who doesn't live with sickle cell disease. And then, of course, that improved health and mortality. Not having to worry about, is this disease going to kill me? How can I live better if I have to live with sickle cell disease? Having access to gene therapy changes the trajectory of individuals, families, and the entire community. And so it's important that we understand that the impact is very real, it's very tangible. In January, just a day ago, but a month ago, the Kansas DIRB became the first to cover gene therapies for sickle cell disease. The disease, DIRB being the Drug Utilization something board, review board. The current federal administration announced that sickle cell disease will be the first focus of a new model of reimbursement. That testing of that model begins in January of 2025. However, participation in that model is voluntary by state, and states must expressed their intent to participate by April 24th. Suffice to say, the sickle cell community needs your help in moving this along, and we're counting on you. So again, I'm Ray Blaylock. I'm the president and CEO, but most importantly, I'm the mama of an entire community of individuals living with or affected by sickle cell disease. So thank you for your time.
Thank you so much, Ray. And I want to just remind us we're at 1:05 for our time, but I would really like Scott McGowan to come on the camera. And I think it's really important what Ray called out, that, you know, for my own patient community, full disclosure, my daughter had metachromatic leukodystrophy, and there's also a gene therapy set to hit the market soon. Ray, I like the way you brought out the availability of some of these transformative treatments versus access. I used to think that an available treatment was what we needed, but what good is an available treatment if there's not access to those treatments? And we know that that's why we're all here, to talk about how we can make sure that availability also translate into access. And with that, Scott, I would love for you to talk through a little bit about, you know, we know that the gene therapy for sickle cell disease is, the data shows that it's highly effective. May we say potentially curative, but talk us through a little bit some of those access challenges and what you're seeing.
No, and I appreciate that, and it is a very esteemed and difficult panel to follow, particularly Ray. The one moniker you forgot there was RDAC to follow, in addition to all of those other titles you bear. In full disclosure, my name is Scott McGowan. I am the Executive Director of Policy and Alliance Development at Vertex Pharmaceuticals. As a full-time employee of the company, I do obviously have financial interest in the company, so I just want to make sure that's very plain and clear in the transparency. Well, I'm going to address that access question really in drawing together a lot of threads that each of my other panels have talked about. So I think first and foremost, with the advent of these new gene therapies that are coming to the market, and the first one being approved in 2017, we're in an incredible moment in science where the investment in research and new tools is finally coming to fruition. We're realizing the potential that these types of new treatment approaches could have, and the impact they could have on many different communities, not just here, but around the world. For some pipeline projections, a group called NewDigs, which is run out of Tufts, it has a very tortured acronym explanation, but NewDigs is the easiest way to remember it, projects that there could be 63.5 durable cell and gene therapies approved in the United States by 2030. So right now we're just above kind of the 15 range. That is going to continue to increase. And while we can look at that with trepidation as how are we going to handle this, I think we should also recognize that each one of those represents a potential benefit and a potential new therapy for communities waiting for new medicines. So it is a delightful, it is a fantastic, it is a wonderful problem for us to solve, to ensure access, to ensure patients can have the choice of whatever is the right option for them. The same characteristics we've been talking about here today about what makes these types of treatment approaches potentially very promising, that they are durable, sometimes from a single dose with a long time, potentially lifetime effect, that they are available through limited treatment centers as we're still learning and gaining experience with how to administer them. All those things that again contribute to the potential benefits of these treatment approaches also makes them challenging for our existing healthcare system, which when it was designed, whether you were talking private or you're talking government insurance, they weren't developed with a one-time or durable therapy in mind. They were designed around chronically dosed medicines that one would receive every day, every week, every month, every year. And so that fundamental mind shift is a challenging thing in a world of regulations and policies. So again, when you have these new types of disruptive treatments that are disruptive in a positive way for patient care, they can be disruptive in a challenging way for our healthcare system. It's something we've in fact found as more and more of these products have come to market. Lots of different solutions and approaches are being talked about right now. We've talked about here already outcomes-based arrangements whereby the actual total amount paid for a drug would depend on how well that drug worked in a pool of patients, at the national level. Again, there's lots of different ways to think about it. There's also things called warranty models, where a payment could be paid back to the insurer for a failure to address certain outcomes. There's the Center for Medicare and Medicaid Innovation, which has been invoked twice here. Ray did a great job summarizing on her second to last slide, where again, they're going to be piloting CMS negotiating these types of arrangements that could be implemented beginning next year. And each one of these, again, represents potential approaches. And there are others too, like high cost, low volume risk pools or differently defined risk corridors that are being explored across different states. And so these are all different tools. There's no one size fits all. It will depend upon the population, the drug, the availability of an outcome measure to be considered, as well as just seeing what works the best. And what worked best for Minnesota may not be what works the best for Rhode Island or Alaska. So we also need to be creative and flexible in our thinking as we are also being innovative in how we're developing medicines. I'd leave it with a couple of quick thoughts and recommendations for Minnesota itself. I think first and foremost, we as a community of stakeholders, and each one of us speaking here today is a critical voice and a critical role. And I would strongly double click on Ray's that there is no more important voice than that of the community, that they need to be central in this discussion. But we need to be looking ahead at what is to come, because the cell and gene therapy field has been long awaited for a long time. The first trial in a human was in 1989. We are now at the point where we're realizing the investment, realizing the gains of the investment and the dogged efforts of scientists, researchers, and community members who supported and participated in research to bring us to this point. So we need to look ahead and anticipate these changes, whether it's cell and gene therapy or whether it's the next transformative class of therapies that doesn't exactly fit. Because when they arrive, the question should not be if patients have access, but how patients are going to have access. And we can come to those solutions beforehand. Second is that communication is key. There are certain regulatory limitations on the amount of conversations that can be had between manufacturers and Medicaid programs. In the state of Minnesota, there are 2 30-minute meetings provided a year, not more than one in any 6-month period. And for a manufacturer who may have existing products they are trying to ensure patients have access for, they also may not have the time then to talk about what's to come and how the state should be advancing or considering their options so they know what to do when the new types of therapies arrive. So communication is key, and something that I would argue could be rectified and remedied very easily by simply allowing for those types of meetings, whether it's with a trade group, whether it's with RDAC, whether it is with so many other forums that represent broader than any one interest, but really the interests of patients and fields of investigational medicine. And then the third one, again, is just returning back to this: patients shouldn't be left waiting. What Dr. Boucher had discussed earlier, what Ashley had discussed, or Ray discussed about the delays that are oftentimes experienced with new therapies. There's times at which there's careful consideration of data to develop a policy. There are other times at which there's a problem that could have been identified and solved before. And I would argue that cell and gene therapy is one where Minnesota needs new authorities to give them the flexibility to do things differently, to try out new potential treatment, new potential reimbursement avenues, things that aren't permitted under the very prescriptive state statutory code. And so again, something where we can do a lot of thinking ahead of time. We can plan to give the state the tools it can use at its own discretion to find appropriate solutions that prioritize patient access. And again, I think it's something we all have a responsibility to do together, to come together in our shared mission of transforming patient lives and ensuring patients aren't unduly burdened in their trying to make whatever choice is right for them, and ultimately to realize the benefit of all of this investment, all of the contributions, and all of our collective work together. So I want to make sure we have ample time for questions, so I did truncate quite a bit, but again, appreciate the opportunity and happy to take any questions.
Thank you so much, Scott, and thank you for catching us up a little bit on the time. I know that this is a huge topic and you all probably feel like you're drinking from a fire hydrant, but I wanted to kind of call out what Scott said here at the end that I think is so important and part of the reason that we are addressing this in RDAC, and that's that, I know that we have, we're focusing on sickle cell right now, but truly we're talking about a whole class of medicine. So we're talking about a new technology. Gene therapy represents a new technology across different rare disease spaces. And so to that end, I've asked Dr. Paul Orchard to moderate the Q&A time. So Paul is one of our members on RDAC, and he actually works historically, he's been working in the bone marrow transplant space. And so Paul has really seen in his own patient community this shift from being able to manage these diseases to potentially having curative treatments to offer. So Paul, I'm going to let you moderate. I don't see any questions in the chat, but if anyone has a question and wants to raise your hand for any of the panelists, otherwise,